Good afternoon, and welcome to our session. We're very excited you're here. We're happy to be here. Today we're going to talk about rethinking patient support with digital and technological integration. Easy to say. Future journeys are inside out, not outside in. I'm excited to introduce our faculty today. My name is Dierk. I am co-president of Aventria Health Group, and with me is Casey Cormier, who is co-founder and principal of Stratus Group, and Chuck Stevens, who is the former CEO of Cormier. So quickly, what are our objectives today? We are going to contrast outside-in models versus inside-out digital support models. We'll explore the interactions, for example, real-time benefits, copay, notifications, prior auth, triggers that can transform and accelerate speed to therapy. We'll showcase how digital ecosystem notifications based on history, activity, and prescriptions can proactively detect and support patients before the hub ever sees them. We'll describe how pharma life science companies and specialty pharmacies should design support programming at the moment of prescribing and within the EHR ecosystem in order to integrate with the prescription journey. And lastly, we'll discuss how hubs and pre-hubs of the future will evolve and thrive. So this is what we all know, that this is what the prescription journey looks like. It starts with prescribing. Patients go into the funnel. We then get approval of insurance and coverage. Then the brand gets dispensed, and then the patient picks up the brand at the pharmacy. And that's how it works, right? Or this is what happens. And so the reality is that that funnel is an imperfect funnel. That process is an imperfect process with lots of problems that are well documented. So there's patient leakage all along the journey, and it's significant. It can be 25 to 40% of patients never receive that initial first script. Then there can be another 20 to 35% that only get the first prescription and none thereafter. And only a third of patients will complete a full course of therapy over a 12-month period of time. Or put another way, 2/3 of patients will stop therapy early. So this is a terribly costly situation for everyone involved. And this problem's getting worse. CVS has been presenting this data persistently, showing that for novel brands, this data is over 50% of scripts don't get filled for a patient. So it's a real challenge. Yet there are opportunities to make improvements here, and that's what we'll talk about today. Okay. I love this slide. This is a great example of where the problems can lie. So if you're looking at data relative to that prescription journey and the follow-up points, there are myriad areas of problems that can be identified during the journey. So these insights are available and can be leveraged to act upon those problems and try to recover those lost prescriptions. So insights can be available and they can be leveraged. However, if we think about where we are, we start with what does the traditional model look like? And the traditional historical model is an isolated one where support is focused on a central hub with incomplete system visibility into these infrastructure pipes. So they're operating on the outside, looking in. Then there's stage 2, where there's some insights because integration is beginning And while there's still gaps, there's then also visibility and activity tied to the visibility. And then lastly is the future hybrid model, where there's integration across these different sectors so that this information is more complete, more actionable, and more impactful. And that's what we're going to talk about, how to execute support actions directly within this clinical workflow vis-a-vis that integration. So at our company, we looked at a client recently, and we compared 2025 performance to 2026 performance. This is a multi-billion-dollar brand. And in the current outside-in model, this brand was only dispensing 70% of the. We believe that within the inside-out model, that can be improved, not completely fixed, but improved to 80 to 92% dispense rates, which recaptures then 10 to 20% more patients, which is meaningful for providers, for patients, for payers, and of course for the drug manufacturers that are trying to drive appropriate utilization. Overall, this brand was losing 25% of total scripts. With the inside-out model, we believe that 50% of those lost scripts can be recovered. And 9% of scripts never got outside of the PA process. They were stuck indefinitely. And 60% of those can be recovered. So you start to add up these recovery efforts, and they become very impactful, very meaningful, and valuable, and I think critical and necessary. So lastly, how do you do that? And the idea is to look at the pipes within the EHR or clinical workflow ecosystem and capture that patient data and the journey data and pull it all together so that you can understand the activity, the history, and the prescription status by integrating all of these different insights, identifying problem areas. So if things run smoothly, which is 50% of those prescriptions, then that's fine. But for the 50% that are falling out of the funnel, this is super important. And so the whole idea is to align these different inputs so that you can see the entirety of the journey, and then you can take action upon that in near real time. And that matters. And the whole idea, aside from improving dispense rates, is also that you can drive speed to therapy. So we're here today to have a panel discussion and talk about what we're seeing in the market and where things can move to, understanding what good looks like and what's newly available and how to react. So let me start with my panel and ask, what are you seeing and what are you hearing in the market relative to these gaps, and how do you think you should be taking forward?
Can I tee up first?
Yeah.
All right. First, before I answer the question, can I take a survey in the crowd? How many of you folks work in life science organizations, manufacturers? All right. How many service providers, vendor partners? All right. Patient advocates? Specialty pharmacy folks? All right, last one. Other? What is another? What's an other category?
Standards.
Standards? There was one more hand somewhere over there.
Consulting.
All right, okay, good. All right, so, Dave, interesting question about the gaps. There's obviously a lot of gaps in the market. I think the one that you pointed out, so I'm going to focus on two, I think, but the one that you pointed out is the first one that I'm going to go to, which is the visibility aspect in the RX journey. So if I were an executive in a life science company, I would be hyper-focused on that question. What is the RX journey? What does it look like for our product? And it's going to be different for every product. So the big old school models, and I've been in the market for a lot of years, as you can tell with my gray hair, they don't work, right? Everybody tries to put that same puzzle piece together into the new organization that they go to, and it's not working. So the visibility into the RX journey is mission critical. You have to figure out in this market, which is incredibly complex, how does the patient consumer, the ultimate end user of the product, who has absolutely no say in anything other than paying the bill at the end of the day, right? How do you get that patient consumer connected with the provider who says, this is the product that you need? So hypervigilance, hyper-focus on that is mission critical. And I'll give you the case study as my own case study from, I hate to say it, over 3 decades ago. So I started in this business carrying the bag for Abbott Labs, which was the precursor at the time I was in the division. It was the precursor to AbbVie, so I was in the pharmaceutical products division. So if I saw a doctor at 11 o'clock in the morning and she or he said, Chuck, I just wrote 10 scripts for Biaxin, I knew 8 or 9 of those were getting filled. For the last quarter century, think about it, quarter century, it sounds awful. More than 2 decades, we have been wrestling with the same question. How to stop this leakage, how to figure out what's happening, and how to make sure every script gets filled. And not have the physician fatigue out, because the physician and their staffs are critical in this piece. So having a viewpoint and having an understanding, a complete understanding of where the hurdles, challenges are, because there are many stakeholders, as we know, in that RX journey chain. Some of them are payers, some of them aren't payers. There's a lot of things that go on. Mapping that out specific to your product by benefit type, medical pharmacy combination, route of administration, where is dispensing happening, limited distribution network, retail. And finding out, because at the end of the day, it's like a smorgasbord, right? It's like ordering off a sushi menu. There's all kinds of things that happen that you have to figure out. And I'm sure we're going to talk about challenges and other things coming up, but you can't solve for everything. So you have to focus on the things that actually matter in driving that access for the patient to get therapy. Technology is an incredibly important aspect of that today, all right? And I know I've said something that everybody knows and believes in this room, but the second piece of that gap is the solution itself. We don't have a silver bullet. There is not a one-stop shop model that fits everything. And the technology piece, as important as it is, there are aspects of technology that, one, are very emergent, and we don't know how they work. Two, we went through a period with COVID where we suddenly went from a meeting like this to complete Zoom calls and everything else. A lot of the support programming started to get a little bit more technical, a little bit more digital. But it hasn't solved the problem. It hasn't, and I would argue it hasn't moved the needle enough to where it needs to be. Because if you look at what we're doing from a provider support and patient support program perspective, we're still doing a lot of the same things, right? I ran a reimbursement hub at ParXL in the early 2000s. So I led the commercial practice at ParXL, large CRO. One of my business units was a reimbursement hub. It was, came to ParXL through acquisition. Praycon was the name of the legacy company. That was one of the first reimbursement hubs in the market. My last gig was at Copilot, now Elusa Health. Ran that hub for 5.5 years. Yes, had things changed? Of course. There's automation, there's technology, there's some things that happen, but at the end of the day, we're doing the same types of things. Hubs, copay card support, adherence support through specialty pharmacy, reminders. We're doing the same types of things to start to answer, which is how do we leverage the technological advances to move the needle and actually get patient consumers access to therapy. That's it. If we can solve that, we're done.
I mean, do you have a whiteboard? Should we just?
We should whiteboard it out.
We have all the right people in the room. I'm going to get a little more granular. So I think the gap that I would say is the most urgent to fix here is that at inpatient services, think about it in 2 ways, right? There's the services that we're offering to the patient, and there's the operations, which is how we do it. And classically, it is we need the patient to be pushed out of workflow. We need consent, right? Think about consented, covered entity and a non-covered entity. So that gap right there, where do we get the patient from the covered entity to the non-covered entity through that consent piece in order to help them, right? Every solution we have that's out of workflow needs to tackle that first. I don't care what you build over here, if you can't get your patients over here, you're not going to support anyone. So, when you're designing a program, you're like, okay, how do we do this? And if you think back to 20 years ago, it was enrollment form by fax, right? All the information was connected. And then it came, I would say the most recent kind of disruptive piece was, we'll do a prescribed to pharmacy, ERX, right? And I'm going to skip over eFax and kind of all those pieces, the website, eFax. And what that did was it gave us an ability to do some things in a covered entity place before we had to get patient consent. I think where the future is going is pushing that even further back, right? Because everyone in workflow, all of those vendors that are in workflow, they see these pipes, they're doing these services, they enabled these services really recently for a lot of them. If we can move that moment of consent back and we can have the folks that are in workflow do some of these services, then we will start to close how big that gap feels, and you will start to be able to get the more appropriate patients to your hub, because we don't want everyone to the hub. But how do we filter when we're just doing, website PDFs and the patients kind of signing up for things, and the messages, you have a human telling a doctor or an office manager get every patient to the hub, right? That requires a message. So I think if we can solve the how do we get the right patients, the right services at the right time in the most efficient way, which is by a covered entity if possible, because then we don't need consent, then we can minimize really what needs to be supported out of workflow. So I would say, in general, that would be the first kind of missing or gap that is tackled by doing an inside-out model, is that now you have more services prior to that consent. And I do want to say there's Dave talked about this funnel. There's another funnel that my colleague Jason Reed put together. But his funnel is about where the patients, right, and how they move through that technology workflow. And if you think about it at the top of it, there's all these EHRs, right? It's every patient needs a EHR. And then when you're there, you have vendors that are ERX prescribers attached to the EHRs, and that's a little bit more consolidated, right? You can work with EHRs, you can work with the doctor first, the ERX prescribing widgets. But then you get to the intermediary space, right? And they have unprecedented access, up and down, to pharmacies and payers. And that's the choke point, right? That's where you get this footprint. And then you go down to the pharmacy, and you have vendors that are now consolidating the pharmacy space so the patients have consistent experiences, right? It's all about how do we get the patients into a point to give everybody the same services, and really the same services are the appropriate services in the most efficient way possible. So if we can get the folks that can see into these pipes, right? So you have, you're delivering services at the right time, in the right place, and then you work with vendors that can see into these pipes. And everything we do in CRMs at hubs, like case closes, automatic trigger, case opens, business rules, you can then do in that workflow. And the pie chart, you get those buckets, you get some business rules, you make those buckets smaller and smaller, right? You see a new bucket pop up, you write a new business rule. I really think that that's the future, and I think access services are going to be the first to go in workflow. And I think that if we're thinking really far ahead, it's really disease area hubs are going to start to become super popular, because now you're supporting a patient through their disease and not just through the brand, right? And that really closes the gap, because now you have one entity doing access for all products and then articulating with the specialized services at the hub, and you've pushed the moment of consent way farther down the path.
So Dave, may I ask the audience a question?
Yeah, please.
So, why are you laughing at me?
I love it.
We're good friends, if you haven't noticed. On that point, so Casey went over a lot of the integral parts of what's happening in the process. For our friends who are working for life science companies, how many, so there's a lot of moving parts with what you just said, how many of you have a good handle on understanding from your brand or brand's perspective? How many scripts written, how many dispenses, and why the leakage occurred? Why everything didn't get written, didn't get filled?
And if you do have that visibility, is it delayed? And are there gaps? right?
That's right.
Yeah.
So I didn't see any hands and I didn't see any heads nodded, because I think that's exactly what we're trying to solve for here. So you know, not to jump to solutions, because we still have to talk about some other things, but understanding that is critically important. It's not an easy way to do it. So I think that we'll get to. I don't want to take away from Dave's questioning and moderating the panel of some of the things that might be happening in the market. But I want you to keep that in mind, because it's probably not a one-stop shop. It's probably a combination of things, and it's a very challenging question to answer. It's an easy one to ask, it's a challenging one to answer, and you'd be surprised with the amount of life science folks we talk to, what the response is when we ask those types of questions. There are some people in the market who think that what they have deployed, a combination of people assets and technology assets, have figured it all out and they don't have any issues. And then there are folks that know they have issues, but they don't have visibility into where they have the issues or why they have the issues. So they're playing whack-a-mole every day. It's student body left, student body right when something comes up.
So Chuck, you either read the set of questions or you anticipated my next question. I'm not sure.
Isn't the mentalist guy playing here?
The question I want to ask is, for Casey, what you articulated what the future, what good looks like, is what are the challenges we have today that inhibit us, that we have to overcome to get there? And I think Chuck just answered that first by saying, you know, data insights and understanding the unknown, and what is the problem, what's its magnitude, where does it lie? What other challenges do you see?
Yeah, it's a good question, because I think that we can get directional insight from the data that we get kind of at the switch, which is way far down the workflow, denial codes and whatnot. Like you can see kind of all this stuff delayed. I think that a more kind of emotional challenge would be, we're used to having a one-stop shop. We're used to having one path to the support, right? And maybe copay and, you know, a little nuance. But and what we have to start to embrace or feel okay about is you're going to have many layers of operations to support different patients in different places with different services, and that gets really, really tricky. And it's not a linear, like, you know, we collapse a patient journey into like a series of chevrons that are across the top of the page, right? But we all know that there's really no right way to order those chevrons, right? Because patients are going to go from here to here to here to here, right? And so then there's the process flow as well. By expanding your operations from that one pipe here to, okay, we're going to have something operationally supporting this service with this patient bucket here, and another set of operations, and another set of operations, you are actually simplifying all of your process flows as well, right? Because now you have fewer patient types going through here. But it is a really difficult leap, especially in an era of vendor consolidation. Fewer dollars available. What we see actually is that the brands that are killing it are the ones that are like, we'll try anything, right? Because they have the dollars for it. Because it takes implementation dollars to deploy these solutions, and so they'll do 3 or 4 things, right? And so there's the shift around having multiple vendors and multiple pathways and multiple operations, and then there's that shift around, in order to pull through patients and be part of the revenue cycle, you have to spend some dollars on implementation, which means you need to be able to quantify the impact it's going to have on your revenue, right? And that is also a pretty big leap in this day.
So that's, I think you're 100% correct. I'm going to take a step back from where Casey had us and talk a little bit about the beginning of the challenge. So we're all talking about challenges and how do we solve for it. I think it's like brushing your teeth in the morning. You know, you look back at the person in the mirror, right? So what is the real challenge in the market, especially if I look at it from the life science manufacturer perspective, and I say, okay, what would I advise? Free consulting's worth what you paid for. What would I advise a manufacturer to understand about the challenges in the market? 1, the market moves really fast. 2, pharma organizations move really slow. Okay? So, and it doesn't matter whether it's a mid-tier company, if they brought in people from, you know, mid-late career people like me, We have a way of doing things, right? There's a slowness to adopt, and Casey said something very important. The organizations who are most successful in the market, they haven't necessarily figured out all the dynamics in the market because there's so many stakeholders in the US market segment in healthcare, it's impossible to have a solution for everything that can come up. But the ones that are successful are trying different things, and they're trying new things. And so I would add these 2 points. One is a story, and one is what my thought is about moving forward to have a holistic solution that might work. So first thing is, a couple of years ago when I was at ICON, a very large, top 10 global, fully integrated pharmaceutical organization came to us and said, listen, and I want to say it's not because of a lack of trying from the manufacturer side, right? You're spending a lot of money deploying all kinds of things, trying to support patients, right? Being true to the 2 things that pharmaceutical companies sign up to do. One, you gotta make money, right? You have to be profitable to keep the lights on. So if you don't figure out this thing that we're talking about, you're leaving money on the table. And the second thing is, I've never walked into a pharma company that hasn't had somewhere a reference to patients, patient centricity, patient-centric, patient-focused, right? So if you're not getting the patient consumer access to therapy, you're failing on that mission. So this manufacturer came to us and said, we are spending gazillions of dollars, and we have a 1-800 number, a toll-free, it was probably 1-866, there's no more 800s, I'm dating myself.
I'll take it.
It was only a couple years ago. And said, we have a toll-free number in the US. We get annually over 250,000 calls from patient consumers, and like 99.89% of the calls are complaints. So it's not through a lack of trying. It's a lack of execution, and execution with success, with metrics that matter. And I would suggest, to amplify what Casey said, I think the next critical element is you have to understand, even in a world of consolidation where folks are doing multiple things, some entities do some things better than other things that they have in their stable, right? So my view is, if I were, whiteboarding and creating the perfect solution for a life science company, you gotta get a multitude of vendors in the room, because there is not one silver bullet, as we said. You have to say, okay, what are we gonna solve for? What's the strategic approach? What are the workable solutions to get us to where we need to be? What do we think is successful for the investment? And then you gotta go out and find the vendor partners who do those things that you need to action really well. And you need to tell them up front, listen, we think you're best in breed, best in class doing this thing. We know you do A, B, C, and D, but we're gonna bring you in for this thing under 2 conditions. 1, you never try to sell us something else. And 2, you play nice in the sandbox with all the other vendor partners that we bring in. And for the vendor partner side, that's a tough thing to do, right? So if you're a manufacturer, you've got to get them comfortable with it, because the decision-making process, I'm not telling you anything you don't know, the decision-making process in all your organizations, they're siloed, right? And we've all been to bid defenses where 17 people come in a room because you got to check the box of legal compliance, this, that, the other thing. Half the people don't know each other in the rooms. The first time they're meeting, 90% of the people are on their laptops. And all you're doing is moving something through a process, and you're buying individual things that look like they come together, but they don't come together. And I think that is a very important piece, because the technological piece is one of the linchpins here. You're gonna have to integrate multiple entities within the technological frame to be able to support success in this new market. And the market is changing, as we know, pretty quickly. And those are, I think, some of the things that you really have to wrestle with. So when you go back on Monday and go back into the office, that I think is the hard discussion. There's all those books, Dead Moose on the Table and all these things, and Don't Move My Cheese. That's the hard discussion. If you want to solve the problem, you got to think of a different way to do it.
Actually, I'm going to flip it on its head. I would say the first thing I would implore you guys to do is to invest in studying the pipes, figure out who's doing what in the workflow, in the EHR, in the payer space, in the who's doing the adjudication, claims adjudication, like what does that look like? Because then you'll understand, and not just who's doing what in those pipes, what are they offering manufacturers? And what are they enabling in EHRs and Epic, and what are they enabling in benefits? Yeah, where you can get better data so you can get a better idea of where you have leakage, right? Not only that, once you have better data and better insights, and we don't necessarily want raw data anymore, we want a trigger that sends an insight to a person that can do something about it, like an FRM or a PAL or a FAM, whatever you call it. There's that, you have now just turned a technology foray into a data exploration into a person. You're enabling your people better by understanding where you have better data available in real time, more granular, so they can go and make an impact, right? There's a lot of new data out there, and it's not in like the flat files of yesteryear. It is in real insights, not necessarily, you're not going to get this kind of, then this happened, then this happened, then this happened, and we kind of have to, we have to feel uncomfortable with that. And you mentioned brushing your teeth, and this morning, I don't know why I brushed my teeth when I left bed just to see what would happen, and it was really uncomfortable. We're going to be like uncomfortable for a little while, you know, but I think that's what's going to make the paradigm shift.
And you know, you brought up the data piece. Data, everybody, we've been talking and have had esoteric discussions in places like ISPOR, if you're familiar with ISPOR, about data for the last 50 years. Nobody trusts anybody else's data. And one of the challenges that if you're in the life science companies, one of the challenges for your vendor partners is when they provide insights and data sets, and then you run them through different groups, either within or outside of your organizations. And then you come back and say, well, this doesn't match up exactly what Casey was saying. It's not linear, it doesn't flow. How come you're seeing this and getting data over here and stuff? That is a critical piece to this. To deploying technology, you're getting metrics back, you're getting data back, and you're getting some manual data from other elements of what you're deploying to provide access solutions to patients. That data discussion is another important discussion, and how you're going to marry it up, how you're going to accept it. But at the end of the day, there are certain measures that we have that we can test whether or not we're doing well and achieving what we've set out from a strategic perspective, our goals for the deployment of whatever that we're doing.
You know what's hilarious is that that's another gap. We get so many of our insights from data vendors that can't help us do anything about it.
Yeah.
Like, let's get insights from the data vendors that can help us do something about it, right? That can code up business rules. I mean, we rely on QBRs and we get upset when they don't bring things to us like, why didn't you bring this to us, earlier? And you wait till this QBR. It's because they can't do anything about it, right?
Okay,
Gotcha.
sorry. It's hard to get a word in edgewise with these people.
Perfect.
They're a lot of fun to work with them. I have one last question, and before I ask them, I'm going to answer it so that I have an opportunity to weigh in. And the question is, what barriers limit our ability to act? And that's the important verb here is act. And from what I've seen, there are two interesting barriers, and they're evolving and opportunistic. And the first one is, now that we're talking about new data insights and new availability and a deeper dive on what's happening, what gets measured gets managed. So without asking any of you, right, you don't have to raise your hands, but think about this data set, or think about that data set, and think about your organization and who has objectives to improve performance from a quant point of view in this space. And our experiences are that that's pretty limited today. And so now that you have new insights, you can put management structures in to improve and act upon those insights. And then the next point is to also think about organizational buy-in, right? Because as was inferred here at the table, there's a lot of stakeholders at these large companies that may have influence in this process. And you have to think about how do we, I can show any of these three last slides. You know, how do we coalesce the happening, bringing together all of these different stakeholders? Other barriers that we want to address?
I think Casey talked about the clinical workflow a lot. That I think is one of the greatest barriers, right? If the solution cannot be made efficient for the providers in being part of the clinical workflow, it becomes a challenge, right? So, you know, if you've got some, you know, novel rare disorder product that requires a lot of hand holding throughout the process, you know, maybe you can get away with having, you know, the providers get into another system, another portal, and do that. You know, increasingly, the reason why you haven't seen a lot of uptake in some of the deployment of some of the great solutions that are out there in the market is it requires the provider to do what? Get out of her or his workflow and go do something else. And that becomes challenging, especially when you look at the business of medicine today, and you've got specialists that are just doing thing after thing after thing without time for lunch, right? It's different. So anything that gets them out of their workflow, I think, is a challenge, a barrier, and that's where these solutions have to begin to, if not wholly reside in the clinical workflow, at least have some type of messaging, engagement, communication, call to action within the workflow that allows the provider to then access some of the other solutions that are being offered.
Okay, we have 2 minutes. Does anyone have a burning question they want to ask? Okay.
All right. Thank you for coming.